So a very good morning to everybody. I'm very happy. Hi, see some familiar faces. Very happy to be here with you this morning, and thanks to the organizers for the kind invitation and the opportunity to share with you some thoughts to break the ice, and then we will very likely moving forward with a very engaging meeting. So I want to share with you a couple of perspectives with respect to the discussion that we are having this morning. Of course, I will try to explain why a learned society as the European Society for Medical Oncology, ESMO, is involved in and interested in this type of discussion, but also my perspective. Len, I'm not sure that this is working, so if you can yeah, next slide. Okay, this is the declaration of interest, and I have known for the purpose of this talk. The reason why the society, ESMO, is highly involved in discussion in terms of access to, it's not only a matter of access to cancer medicine, it's a matter of access to the optimal pathways of care, is the promise that we made and we have to fulfill with respect to the universal health coverage that includes, of course, all set of intervention, including cancer packages. And guys, we need to move quickly because this promise we made it to be true by 2025 and 2030. So it's just around the corner, and this requires the engagement of everybody in terms of ensuring access to every intervention that is needed, from prevention to support of survivorship, including access to pathway of care. I'm sorry that the slides are not showing properly, but there is a bottom line that is very important, and I will phrase it, and it regards when we talk about access, we need to keep in mind that there is a high degree of inequalities in access, and we want actually to move to cancel that. Next slide. In terms of my perspective, and this is a slide that I prepared a few years ago, as a medical oncologist, this is what I am, this is my main job. I have the feeling that, there are above my head a lot of drugs, some of them are good, some of them are not, in research and development, and then we start to trimming them down, some of them land on the regulatory desks. Then there is the discussion at the HTA level with some type of, let's say, perceived disconnection within these two levels. Then there is of course, further down, the decision about reimburse this option. And then at the hospital level is where I, as a medical oncologist, I'm stuck with, all these potential options. Some of them are transformative, and yet there are a problem to access. Next slide, please. And we know that there are actual access problems and inequalities, because this is an update, just a snapshot of a recent update of the anti-neoplastic medicine survey that was run by ESMO, the first round in 2015, published in 2016, and that actually show a high degree of inequalities and disparity in access to cancer drugs. Here it is an update that has just been presented at the ESMO Congress in Paris a couple of months ago, and unfortunately, depending, of course, mainly by the income of the country, there are still a high degree of heterogeneity in access, so patients are discriminated depending on the country of the region where they are. And I think that this is, again, should attract our attention, move forward to try to level up these inequalities. Next slide, please. We are not talking today of other problems. We are mainly focusing on the discussion. Well, not really, because they are intertwined in terms of access to drugs, but the same problem, and again, this is another snapshot, is concerns the availability of genomic tests, which actually are linked to the majority of the treatment that nowadays we prescribe in oncology. So this is another angle that sooner or later we need to capture in our discussion, because otherwise focusing also only on the drug will not solve the problem, possibly will worsen it. Next slide. From the discussion that there are different levels, and for instance, from the recommendation from the WHO on how to improve access and affordability of cancer medicine, The indication is try to control, of course, the expenditure on cancer medicine, try to prioritize the cancer medicine that actually are transformative and are impacting in a very positive way on the patient history. So we can prioritize medicines with high clinical value. We need to stick to evidence-based clinical guidelines that, in light of the advancement of science, need to be properly updated, so they should be living guidelines. And sometimes we need, even if it's not optimal, to continue to do research that is partly, let's say, represented by what we call real-world generation or real-world evidence, but not only, in terms of defining post-approval and once the drug is available on the market, which are the questions that have not properly addressed during the drug development. And then this is another topic for discussion, because actually we should get it right from the very beginning. But if not, because this may happen during drug development, we need to pay attention and consider the entire life cycle of the drug. And I'm sure that you are well aware, because now it's a few years that the society is discussing the tool that has developed, the ESMO magnitude of clinical scale benefit, which basically embeds a series of parameters from metrics related to survival, safety, so toxicity, quality of life parameters, and others. It does not incorporate cost on purpose. And basically the evaluation, the assessment that is done through the MCBS hesitates in a score, which may help clinicians and which may favor the discussion at the HTA level about prioritization of cancer drugs, with the scores that are A and B as high score in the early cancer setting, and 4 and 5 in the advanced setting, that basically support, represent an alert and say, look, this is something that needs to be prioritized because it may be really important for a patient. Next slide. Now, I'm really sorry because this slide is really busy and doesn't show properly, which is really the worst combination ever, but trust me, okay, this is again a slide that I borrowed for one of the presentations at the ESMO 2022 in Paris. Basically, is a collaboration between ESMO and the London School of Economics, with the idea of developing what we call a geographically adapted reimbursement model. And the idea is, okay, with the MCBS, we addressed or attempt to address the question, which are the drugs that we want to prioritize based on their efficacy, on their clinical, on a clinical set of parameters. But now, if we want to move forward and we want to discuss, the topics in terms in the field of HTA or reimbursement, let's try to build a model which heavily rely for the quality part of the clinical efficacy part on the MCBS, and will build up with the incorporation of other parameters, which, for instance, regards the gross domestic product of the country, the societal judgment, many factors that are basically assessed, and this work has been presented. This is the first part of the work related to the reimbursement model that has been presented in Paris, and basically addressed two questions. So the factors that are associated to time to coverage of new drugs, and then factors that are associated with the outcome of HTA assessment. So the question is, does basically, very synthetically, is the MCBS like the right building block that goes along with the decision that have been taken, for instance, by HTA? And I think that this is a very relevant question. Next slide, Hélène, please. So, and in terms of time to the HTA cover recommendation, so the work has been done by reviewing 360 published reports by the HTA. And in terms of the question, time to HTA cover recommendation, this is not, this slides does not report the correlation with the HTA, but what I found interesting is that counterintuitively, if there is an accelerated approval, and counterintuitively for me as a medical oncologist, as a clinician, accelerated approval does not necessarily translate in accelerated access to patient. What is really helpful, and this I think it's really relevant for the discussion of today, is the parallel review, which is done by where the system exists by regulators and HTA, which is the green bar that you see in the slides, hopefully. Next one. Again, just to very, let's jump directly to the conclusion in the interest of time. So basically, there are a series of parameters that have been evaluated, which actually show that the MCBS high score on MCBS correlate well with the HTA outcome, and having a high score on MCBS will actually shorten to time to HTA coverage. Next slide, Elaine, please. So this is another, it's the other conclusion that I mentioned before. Next, sorry because it's very small. Again, those are the results that I mentioned, and in the interest of time, then you can have the slides and process by your own. Next. So this is hopefully is something that we are discussing today, how to and again, this is my perception as a medical oncologist, how to fix in a way the disconnection that I perceive between the regulatory assessment and the HTA assessment, because in the end what is important is that the drug is available, accessible and affordable, and we need to answer the question, does innovation actually reach the patient, which is the most relevant one. Next slide, Hélène. And hopefully, this is the point where, this is the reason why, again, as a clinician and as a society, we hope really welcome the regulation and the possibility of having a true collaboration and interaction from the very beginning of the process, because what I perceive as potential indicators and what were discussed as potential indicators during the kickoff meeting of the presentation of the regulation is that basically the new process is meant to reduce delays in access, to allocate resources appropriately, and to reduce inequities and inequalities in access. And I think that as a stakeholder group, clinicians may be, learned society and clinicians can be really of help and contribute hugely to the discussion. Next slide. I'm so upset because I don't care about all other slides that I presented, but I'm presenting these slides since ever. So I think that during one of the break, I will come to you one by one to show you as exactly it should be, because the concept here, and this is what I'm saying since ever, is that basically the discussion about reimbursement, about HTA, about regulatory assessment and so on, should really start at the very beginning of the process. And this is what it's really critical to me, and is not happening for a series of reasons. Should not be in sequence, should be inclusive, and I think that we really need to take advantage of the terrific momentum that we are living, where we have a very important and clear political drive, where we can really make for real the early dialogue and a continuous dialogue, try to really involve all stakeholders, and not, I'm not just saying that because we are in this room all together, we feel good people today. No, we really need to do it, and I think this is the right time to do so. And with this, I thank you particularly for your patience with my slides. Thank you.